common pitfalls in emergency resuscitation. We really want to equip you with clear, precise strategies to see these coming and avoid them, ultimately improving patient outcomes.
That's exactly right. Resuscitation is, well, it's incredibly complex. Errors can have really serious consequences.
Yeah.
Our goal here is to break down the most frequent missteps, not just what they are, but importantly, why they happen and how you can effectively manage them. We want to offer insights you can, apply straight away in your practice.
Okay, let's jump in. The first common issue, delayed airway management. People talk about the wait and see trap. What exactly is that, and why is it so dangerous?
Well, this pitfall often comes from a kind of anxiety around intubation. You're hoping the patient will just stabilize on their own.
Right. You hope for the best.
Exactly. But waiting, especially in patients with clear signs of impending respiratory failure or severe metabolic acidosis or maybe an altered mental status, waiting can lead to a catastrophic decompensation.
So you're saying it's a cognitive thing sometimes, like hoping it gets better on its own.
Yeah, it can be. Sometimes it's a bias towards inaction, hoping the current situation improves, or maybe a past difficult intubation makes someone overly cautious. They might miss the subtle signs because of that past experience.
Okay, that makes sense. So what are the key clinical signs that really tell us, okay, this patient is heading for trouble, we need to act now?
You're looking for clear indicators, things like increasing respiratory distress. So rapid breathing rate, you see them using accessory muscles, their oxygen saturation is dropping even with supplemental oxygen, and very importantly, a declining level of consciousness, sometimes that's subtle, and those early signs of hemodynamic collapse, like blood pressure starting to dip. These are major red flags.
Got it. So how do we avoid getting caught in that delay? What does having a low threshold for intubation really mean in practical terms?
Low threshold means you're actively anticipating the need in high-risk patients. You have to be proactive.
Okay.
Identify who's at risk early. Get all your equipment ready, your medications lined up before you absolutely need them. And then act decisively. Preoxygenate effectively. That buys you crucial time.
Right.
Have a clear plan with your team. Make sure you have a skilled operator ready to go. The mindset really should be, if you're even thinking about intubation, the patient probably needs it. Waiting is often much riskier.
Okay. Proactive preparation and acting early. Moving on from individual actions to the team. Let's talk about communication and leadership failures. We've all seen moments where this feels like it's breaking down. How does this really create chaos during a resuscitation?
Oh, it's huge. Without a clear leader and, frankly, effective communication, the team's actions just become disjointed. It's inefficient. This often happens because roles aren't clearly assigned, maybe instructions are vague, and you've got the inherent stress of the situation amplifying everything. It creates this massive cognitive load for everyone involved.
Leading to errors.
Exactly. Leading to missteps, medication errors, a real failure to put all the pieces of information together. Think about it if vital information like a change in heart rhythm or how the patient's responding to a drug doesn't get to the whole team. It's like trying to navigate blind. And if no one's clearly designated as the leader, you might get conflicting orders. Or worse, no one takes charge of critical tasks.
So what are the visual cues? Like if you walk into a resus bay, what tells you communication is falling apart?
You can often see it. You might see team members just standing idle, unsure what to do. Or the opposite, multiple people shouting instructions at once, just noise.
Chaos.
Yeah, chaos. There's confusion about who's doing what, a general sense of disorganization. You just don't see that coordinated effort you need. Vital signs might change, and maybe only one person notices.
So how do we fix that? How do we manage it?
Key thing is, establish a clear team leader right at the start, if possible, even before the patient arrives.
Okay.
And that leader must assign specific roles: who's on airway, who's doing compressions, who's pushing meds, who's documenting. Make it explicit.
Right.
And then use closed-loop communication. It sounds simple, but it works. Leader says, give 1 milligram of epinephrine. The responder confirms, okay, giving 1 milligram epinephrine, and then confirms again, epinephrine 1 milligram given.
So everyone knows it's done.
Everyone knows, no assumptions. Also doing a quick pre-briefing before, if you have time, and definitely a debriefing after the event. That helps teams learn and improve communication over time.
Good points. Okay, third pitfall, tunnel vision. This feels like a very human thing to happen under pressure. Why do providers sometimes get stuck on just one number, like blood pressure, and how does that hurt the patient? It's
a classic cognitive trap. Sometimes it's called anchoring bias. You're Focus just narrows right down onto one piece of data, maybe blood pressure, maybe heart rate, and you stop considering the underlying reason for the instability.
Right, you treat the number, not the cause.
Exactly. The intense pressure makes you want to fix something, so you treat the symptom. A common example is just repeatedly giving vasopressors for low blood pressure without thinking, wait, could this be a tension pneumothorax? Could it be cardiac tamponade? You're treating the alarm bell, but ignoring the fire itself.
So how does this actually look in the moment? What are the signs that a provider, or maybe the whole team, is stuck in that tunnel?
You might see them giving the same drug or fluid boluses over and over without really pausing to reevaluate the patient or think about other possible diagnoses. They might be staring intently at the monitor, but neglecting a hands-on physical exam or, crucially, a quick point-of-care ultrasound check. And typically, the patient just isn't getting better despite all these symptomatic treatments because the root cause isn't being addressed.
So how do we fight that? How do you force yourself or the team to zoom out?
You literally have to consciously force a pause and zoom out. Consider the whole clinical picture. A really effective discipline strategy is to mentally, or even better, verbally, run through the H's and T's during every cardiac arrest.
Remind us what those are.
Sure. Hypovolemia, hypoxia, hydrogen ion, meaning acidosis, hyperkalemia, hypothermia. Then the T's, tension, pneumothorax, tamponade, toxins, thrombosis, both pulmonary and coronary.
Okay.
These aren't just random causes. They're often reversible if you identify and treat them quickly. And this is where point-of-care ultrasound, POCUS, is just invaluable. It lets you rapidly look for things like tamponade or a massive PE right there at the bedside. Helps break that tunnel vision.
That makes sense. Okay, next up, fluid overload. You mentioned thinking has changed here. How can giving fluids, which seems intuitive sometimes, actually become harmful? And what should we be watching for?
Yeah, the paradigm has definitely shifted. It used to be pretty standard to give large volumes of fluid almost reflexively.
Right. Fill the tank.
Fill the tank, exactly. But we now know that can be really detrimental, especially in patients with cardiogenic shock where the heart's already failing, or even in some types of distributive shock if cardiac function is poor.
How does it cause harm?
Well, excess fluid increases hydrostatic pressure. It can push fluid into the lungs, pulmonary edema, making oxygenation much harder. And if the heart is already struggling, dumping more volume into it can actually overstretch the muscle fibers and reduce its ability to pump effectively. It's counterintuitive, but you can worsen cardiac output.
Wow. Okay, so for the clinician at the bedside, what are the signs that a patient might be getting too much fluid?
You'll see their oxygen saturation getting worse. You might hear crackles when you listen to their lungs. That's fluid. You might see peripheral edema. And a key sign is that you're giving fluid bolus after fluid bolus, but the patient isn't improving clinically, or maybe they're even declining slightly. That should make you pause.
So what's the strategy then? How do you give fluid safely?
The key is careful titration. It's about giving fluids based on a dynamic assessment of the patient's response. Are they actually getting better with the fluid?
And how do you assess that dynamically?
Again, point-of-care ultrasound is critical here. You can look at the inferior vena cava, see how much it collapses when they breathe. That gives you an idea of volume status. You can look directly at the heart function, check for signs of fluid in the lungs. It lets you make data-driven decisions in real time. Give just enough fluid to improve perfusion, but stop before you cause harm. It's finding that balance.
Okay, dynamic assessment using tools like POCUS. This connects nicely to our fifth pitfall, ignoring reversible causes. We mentioned the H's and T's for breaking tunnel vision. Why is systematically checking these so absolutely vital?
It's fundamental. The official guidelines, like from the American Heart Association, strongly emphasize looking for these reversible causes during any cardiac arrest. If you don't systematically review the H's and T's, you might completely miss the actual underlying problem.
Like what kind of problem?
Like a massive pulmonary embolism or severe electrolyte abnormalities like hyperkalemia or maybe an overdose or tension pneumothorax or tamponade. Things that can be fixed if identified. If you miss the underlying cause, the resuscitation is likely to be prolonged, ineffective, or just fail altogether. It's a critical diagnostic failure.
So how does that failure actually look in the resuscitation bay? What are you seeing when the team isn't considering these?
You see a patient who just isn't responding to the standard ACLS treatments. The team might be going through round after round of epinephrine, continuing chest compressions, but they never really stop and ask the question, why isn't the heart responding? It just becomes this cycle of actions without the critical thinking piece.
Okay, so what's a practical way to make sure this gets done every time?
A simple but really powerful strategy is for the team leader to make it a point to verbally review the H's and T's checklist at regular intervals during the resuscitation.
Just say it out loud.
Yes. The leader can literally ask the team, okay, pause. Have we considered and addressed all the reversible causes? This forces a quick, systematic review. Did we check a blood gas for acidosis or potassium levels? Did we do a quick ultrasound look for tamponade? Did we reconsider the patient's history for possible toxins? That deliberate check keeps it front of mind.
Makes sense. All right, number 6, inadequate post-resuscitation care. So the patient gets return of spontaneous circulation, ROSC, pulse is back. There's often this sense of relief, right? But you're saying the crisis isn't really over.
Absolutely not. Getting ROSC is fantastic, but it's really the start of a new and equally critical phase of care. A major pitfall is exactly that sigh of relief relaxing too soon, becoming complacent. We fail to recognize just how fragile that patient still is.
Fragile how?
Well, the brain and other vital organs need meticulous support in that post-ROSC period to prevent secondary injury. The brain is especially vulnerable. Things like hypotension, even brief periods, hypoxia, or fever can cause significant, sometimes irreversible damage after the initial arrest has been reversed. It's not over. The next fight has just begun.
So what does that inadequate care look like practically?
You might see the team immediately start focusing on, say, arranging transfer to the intensive care unit without first really focusing on optimizing the patient right then.
Optimizing what specifically?
Optimizing their oxygenation, their blood pressure, their neurological status. If that immediate post-ROSC optimization doesn't happen, the patient could easily have another arrest or suffer that secondary brain injury we talked about. You've done all the hard work to get the pulse back, only to potentially lose ground moments later.
So what does good post-ROSC care involve then?
It needs the same intensity and attention to detail as the resuscitation itself. You absolutely need to maintain a mean arterial pressure, or MAP, of at least 65 millimeters of mercury. That's vital for brain perfusion.
Okay.
Be careful with oxygen. You want to avoid both hypoxia and hyperoxia. So titrate the oxygen to keep saturation between 94% and 98%. For patients who are still comatose after ROSC, you need to strongly consider targeted temperature management, aiming for a core temperature between 32 and 36 degrees Celsius.
Right, TTM.
Exactly. And don't forget to dig deep for a detailed patient history if possible. Understanding why they arrested is key to guiding further management and preventing recurrence.
Got it. Intensive targeted care continues. Finally, let's talk about skipping the point-of-care ultrasound exam. How does neglecting this tool really impact resuscitation efforts?
Point-of-care ultrasound, POCUS, it's really become an indispensable tool. It's hard to imagine modern emergency medicine without it. So skipping it during a resuscitation, especially in shock or cardiac arrest, creates this huge diagnostic gap.
Why does it get skipped? Just time pressure?
Often, yeah. Time pressure is a big one. Sometimes it's lack of familiarity or comfort with the machine or the techniques, or maybe just not fully appreciating how much valuable information it can provide in seconds. But POCUS gives you real-time, dynamic information right at the bedside that you just can't get otherwise.
And what are the actual consequences of not using it when it could have helped?
Well, without POCUS, you lose that ability to rapidly check for those critical reversible H's and T's conditions we keep talking about.
Right.
The team might just be guessing at the cause instead of actually diagnosing it. For instance, like we said, giving fluids thinking it's low volume when really it's cardiac tamponade needing a needle. Or giving pressors for low blood pressure when the real problem is a massive pneumothorax you could fix with a chest tube. It leads to delays, ineffective treatments, and ultimately much poorer outcomes. You're potentially treating the wrong thing entirely.
So the solution seems obvious, but how do you integrate it effectively?
The solution is really to make POCUS a standard early part of your resuscitation algorithm, especially for anyone in shock or cardiac arrest.
What kind of views are most helpful?
A quick cardiac view can immediately tell you if there's tamponade or assess contractility or even confirm if there's any cardiac activity at all. A quick lung exam can spot a pneumothorax or widespread fluid. A quick look at the abdomen can find free fluid suggesting internal bleeding. A trained provider can get these key views in under a minute or two.
Wow, that fast.
Yeah, it's incredibly fast and provides invaluable information that can directly guide your next life-saving steps. It really shifts you from guessing to knowing, allowing much more precise care when time is absolutely critical.
This has been incredibly insightful. It's so clear that recognizing and, more importantly, actively proactively addressing these common pitfalls, everything from delayed intubation and communication failures to tunnel vision, tricky fluid management, remembering those reversible causes, and that vital post-resuscitation care. Plus, using tools like POCUS can genuinely make a huge difference for patient outcomes.
Exactly. Resuscitation isn't just about following steps in an algorithm, though that's important. It really requires clear leadership, it requires precise action based on rapid diagnosis, and honestly, a commitment to learning from every single event. Staying vigilant about these common pitfalls empowers all of us to deliver the absolute best care when patients need it most.